Okay. Yes. Good evening, everyone. We welcome you to OrthoTV in association with Uttar Pradesh Orthopedic Association. To introduce today's topic and speaker, I hand over to the moderator.
Unmesh, it's all yours now.
Yeah. Okay. Good evening, everybody. I would like to welcome our faculty who have spared their valuable time and they will be briefing us upon the latest developments. President U.P.O.A. Sanjay Dhawan sir, Vice President U.P.O.A. Is the voice coming there?
Yes.
Am I audible?
Yes.
Yeah. Okay. Ashish Srivastav sir, Secretary U.P.O.A. Anup Agarwal sir, President VOA, Rakesh Singh sir, Vice President VOA, R.P. Gupta sir, Secretary VOA, Dr. Karamraj Singh, our speakers, Dr. Amit Rastogi, Dr. Vivek Trikha, Dr. Ashok Gavaskar, Dr. Arun Kapoor, Dr. Mukesh Jain sir, Panelist, Dr. S.K. Saraf sir, Dr. Gautam Chakraverty sir, Dr. Kaushal Agarwal sir. Special thanks for coming and sparing the time, Atul Srivastav sir, all our seniors and dear friends. So just before I begin, I would just like to brief upon small things regarding Zoom. It's very interesting, but sometimes things can just go out of hand. So first of all, I would request all of you to please put the questions through the chat box only. So then the things can be moderated well. And just requesting all the speakers, we have very tight schedules to just be keep in time. The lectures are for 10 minutes each, and after each lecture, we'll have a 5-minute short discussion where the panelists will come inside, and the last lecture is for 20 minutes. And I request all of us to keep mute on while the lecture is going on to prevent and minimize all the disturbance. So with this, I would request Sanjay Dhawan sir to give his presidential address. Over to Sanjay sir.
Thank you, Unmesh. Very good evening to one and all present here. I welcome you all for joining us today on this U.P.O.A. trauma webinar, the Friday Musing on fracture neck femur, organized by Varanasi Orthopedic Association. I congratulate the team VOA for taking such an initiative and expect many more from them. My sincere thanks to our IOA Vice President, Dr. Atul Srivastav, for sparing time to encourage us. We are honored with his presence. My sincere thanks again goes to our galaxy of speakers, Dr. Mukesh Jain sir from Muzaffarnagar, Dr. Vivek Trikha from AIMS Trauma Center, Delhi, Dr. Ashok Gavaskar from Chennai, Dr. Amit Rastogi from BHU, Varanasi, and Dr. Arun Kapoor from Agra, and a panelist from Varanasi, Dr. Gautam Chakraverty sir, Dr. S.K. Saraf sir, and Dr. Kaushal Agarwal for sparing time and enlightening us with their competitive wisdom that has always been a treat to listen to these stalwarts. I'm sure that every bit of their talk and discussion is going to give us certain practical tips, which shall be very useful in our day-to-day practice. So once again, I welcome you all, and without wasting much of your time, we'll straightforward move on to academics. Thank you. Over to Unmesh, please.
Thank you, sir. Thank you for the words of encouragement. I would request Anup sir to give the secretary address of U.P.O.A.
Thank you, Unmesh. I won't take much of the time. There are few information I want to share. That please be on the time again on next Friday. You'll have U.P.O.A. pediatric trauma session this Friday, coming Friday. And on 18th of July, we have U.P.O.A. orthoplasty course. So we have galaxy of speakers in that orthoplasty course. So do join us on that course. The information will soon come in your WhatsApp group and by other methods. And let me take this opportunity to thank two people. One, OrthoTV, Dr. Ashok Sham and Neeraj Bijlani, for taking care of all the paraphernalias. He is the man who is doing it on Zoom, OrthoTV, and we are on Facebook Live on the U.P.O.A. page and on the YouTube channel of U.P.O.A. also. And let me thank the Johnson Johnson people for taking care of other things to organize these webinars of trauma on every second Friday of every month. So thank you everybody for joining us. Over to you, Unmesh.
Thank you, sir. So without wasting much time, we'll move on with our first lecture. Our first speaker is Dr. Amit Rastogi, sir. Everybody knows him. He just needs no introduction. Very senior, experienced surgeon, very good academic background, a very good teacher. Speaking on newer things in the open approaches to fracture neck femur. Over to you, Amit, sir.
Right, sir. Shall I start sharing my screen?
Please, sir.
Please.
All right. Okay. Can you see me?
Yes, sir. Very well.
Great. Okay. So we have a very a large galaxy of speakers today, and for who all deal with the very new things in fracture neck femur. Fortunately, unfortunately, we have to go there first before we actually start putting all those implants inside. And one of the things which I would be talking about is open reduction and fixation. Now, most of the times, this has been an unfamiliar territory to us because we always kept on thinking that a closed reduction, we were seduced by this myth of acceptable reduction. There was also a fear of avascular necrosis and non-union, because at that time, we did not have very good applied vascular anatomy, which we have been able to get in the last 5, 7, 10 years. And there was this feeling that AVN and non-union basically inevitable and happens at the time of surgery and does not, and as actually not preventable or thing. Even if we do decide how to do the surgery, the approaches, is there anything new there, techniques, how to reduce, and variations of that technique. Do we use standard implants, or do we use standard implants in a new fashion or newer ones? What is the evidence? When you start with a case, the initial assessment planning goes like this. You will always need a very good team. This is not an emergent surgery that if you get a case in the night, you go ahead and do that case in the night only. This should be, am I audible? Unmesh, am I audible?
Yes, you are.
Okay, so this is not an emergent surgery.
Yes, you are very much audible. Yeah.
Okay, so this should be actually the morning first. Always get a contralateral hip X-ray and a CT if you've got a lot of comminution. Recognize that there's going to be an apex anterior deformity. You can use a fracture table because it's a good way of maintaining a good close reduction. But then you must be prepared to do your open reduction on a fracture table should the need arise. The reason for all this is because quality reduction is the only way. This is the only single surgeon controlled variable which can give you good results. As a technical tip, if you have two IITVs, get both of them so that they can take AP and lateral simultaneous pictures. Approaches are the same approach. There's nothing new, much new about the approach, the direct anterior halter approach, a Smith-Peterson, which are approximately similar, and a Watson-Jones approach. Watson-Jones is my least favorite, so I'll come to it first. All of you know it's a TFL and gluteus medius. It's not an internervous approach, and you definitely interfere with the abductor mechanism in the Watson-Jones approach, which is released either by releasing the anterior aspect of gluteus medius or minimus, or by a trochanteric osteotomy. The incision, all of you know, lift up the tensor fascia femoris up and the gluteus maximus and the gluteus down below. You can get, you will be able to see the gluteus medius and the TFL and the gluteus minimus. Make an incision there, and you will approach the this thing. If you need more exposure, you can release the anterior thirds of the abductors, and or you can do a trochanteric osteotomy. But this would lead to a postoperative limp because there will be a damage to abductor mechanism. You can have a superior gluteal nerve injury, and rarely a femoral vessel and nerve injury because from the medial retractors. My personal favorite is the vertical limb of the Smith-Peterson approach, and this approach actually is much more versatile approach than the Watson-Jones approach. You might not use the oblique along the iliac crest approach, but you can use it if you want more exposure. It's truly an internervous approach. That's one of those patients. That's the iliac crest and the and the anterior spinal spine. That's the straight vertical approach right down. And this is the superficial plane between the TFL and the sartorius. Down below, you can go there and you can get a deeper plane, which is like this, so between the rectus femoris and the gluteus medius. In the classical Smith-Peterson, you will have to detach the rectus from the AIS and the acetabulum, while in the Holter, you can just cut it like this. So you identify the rectus femoris tendon, hook it up, and release it. And that is where you will get the anterior joint capsule. This marker is along the T of capsulotomy, which when you do, you will be able to see the fracture site, which is right now. Please note that there is a joystick already put there. So the advantages of the approach are it is excellent access to the anterior joint, shorter length of stay, rehabilitation. But there are dangers also to the lateral femoral cutaneous nerve, the femoral nerve, and the ascending branch of the lateral femoral circumference artery. The applied here is that there is a better visualization in a Smith-Peterson approach for transthoracic subcapital fractures because you're not looking over the top. And the disadvantage is that you need two incisions, one for implantation and one for reduction. While in Watson-Jones, you can with one incision. So I reserve my Watson-Jones approaches for only basal fractures where you can see more lateral and you don't need to go too much medial. Reduction maneuvers, once you do approach it, you can use a simple clamp if you can this thing, or you can use clamps with special tines which have been flattened out, and you can drill holes and you can put those tines inside and reduce. You can also use various clamps, and this is a pelvic clamp which is controlling the varus valgus, and a collinear clamp from the AO, which is actually providing compression. And the important thing is that before putting all this, try and put 2 pins just short of the fracture so that you're not, the reduction is frequently tenuous and you might not be able to hold the reduction for a long time. If you already have pins there, as soon as you get the reduction, you can drive them across. The other technical trip is try and put an anterior posterior shank pin. And this helps in the distal fragment so that it helps control internal and external rotation. You can also, if you've got a 2-part fracture, you can put 2 screws across, one on the distal side, one on the proximal side. You use Jungbluth clamps, clamp them, and pass your wire across. Here, what we are doing is we are using simply a joystick. You manipulate the joysticks to get your good reduction and derotate it. Now the joystick is lying absolutely flat so that you can actually get a reduction which looks somewhat like this. And you can see that there is significant posterior comminution with the posterior gap. Once you have that reduction, you can put your pins across. There are 3 pins here. Normally, right now in this kind of fracture, I prefer to put 4. That's where it is. If you've got a significant posterior gap, put your anterior screw first and compress it properly so that you don't have a femoral neck head roll back. And then you can put your additional screws. And the posterior screw is put last. So this kind of fracture, which you get, you can do a proper open reduction, get fairly good fixation. Are parallel screws the only way to put screws? If you've got a Pauwell's sleeve fracture, you can put 1 or 2 screws parallel into the neck and 1 screw perpendicular to the fracture line so that you can generate compression in between the fragments. This can also be combined with a DHS fixation. I think Dr. Trikha will talk about that. See another fracture line and a Pauwell screw, and a Pauwell screw in combination with a DHS for a vertical fracture. CCS fixation always safe. If you look at this paper in JOT 2019, 10 cadaveric specimens and inverted triangle CCS configuration, all done in fluoroscopic control, all judged to be contained by 4 independent surgeons. Then the specimens were stripped of soft tissues, and they found 4 core extrusions of these screws, 3 thread extrusions, all in posterior superior screws. And this is what the picture looks like. In clinically out. I think somebody is talking on the this thing. And the screw is actually out. If you take a CT, again, you find that the screw is actually out. Another screw, which seems to be in on both views, but as escaped the posterior superior neck. So be very careful about the posterior superior screw. CCS versus DHS, which is better? I think somebody, Dr. Trikha will probably talk about this, but there is, in the FATE trial, there is basically no difference in union rates. But if you pool all the data, SCS has fewer complications and faster time to union, but avian rates are higher in DHS and CCS seems to be better in transcervical and subcapital fractures. Interestingly, Pauwell's 3 fractures, nails were found to be better than SHS or a CCS. We have all been trained that you must allow the fracture to collapse so that the bone apposition is there and the fracture is going to unite. But then this becomes a trade-off between union and hip function. In the FATE 2 trial, they classified mild, moderate 6 to 10 mm, and severe, which is more than 10 mm shortening, which both of these moderate and severe were associated with very poor WOMAC hip scores if the patient had them. Is there new technology to reduce femoral shortening? You can use a DHHS, which is a helical screw system, which does not require any torsion to insert, and which supposedly would theoretically prevent avascular necrosis. You can also use augmentation plates. I think Dr. Gavaskar will be talking about them much better than I would. There are other special devices like Conquest by Smith and Nephew, which has spring-loaded 3 CCS and side plates, which very commonly used in North America. The Targan by Esculap, commonly used in Europe, and the femoral neck system, which I think Dr. Mukesh Jain is already going to talk about. This is the Conquest. You can see that spring-loaded screws and the side plates. A DHHS with augmentation plates, and finally the Esculap Targon system, very commonly. This is also a spring-loaded system. Are femoral neck plates useful? The approach, how do you put them? The approaches are the same, just like we already discussed. But you put the anterior plate first, which reduces the apex anterior deformity. Do a definitive fixation by a DHS or a CCS. And finally, last, you put a calcar plate with resist varicose. Will this cause avascular necrosis? We will come to that in a minute. But is it useful? So 40 femora, only CCS, DHS, a DHS with an augmentation plate, and CCS with augmentation plates, 10 femora each. Load to failure increased by 83%. The CCS instrumented femora had 26% better or higher load to failure than DHS, and constructs with augmented CCS were strongest. And this was a biomechanical study published in 2015. Is it going to cause, are these augmentation plates going to cause avian? The most important artery here is the inferior retinacular artery. And if you divide the head or into quarters, or rather sectorally, with the 12 being the superior, the 6 being the inferior, 3 o'clock being the anterior, and 9 o'clock being the posterior, it frequently courses between the 7 and 8, this thing. So if you're going to apply a plate, which is at 6 o'clock, it should not lead to any compromise unless you have done a lot of dissection posteriorly. So in summary, the level of fracture would determine the approach to be used. We need to try and achieve anatomic reduction. You must pay attention to technique to avoid avian. For open reduction, many technical methods are there. Each of them have their own uses. CCS, you can apply them in different configurations for different fracture types, but you must be beware of screw penetrations. You can augment it by a plate augmentation, which can reduce construct failure in DHS and CCS. And finally, newer technologies aim to reduce non-union and shortening. Thank you.
Thank you, sir, for a very nice and exhaustive lecture on all the open approaches and the newer devices, which lays the background for our next lecture. So while Dr. Trikha is loading the next lecture, I will just quickly request Atul Srivastav sir, is he there, to say a few words for encouragement for all of us. Atul sir?
It's fine, Unmesh. I'm enjoying. We have the best in the field, so I wouldn't like to bite on their time. So, and Amit's lecture was as usual very good. And yeah, there's a paradigm shift in the thinking about, especially about the collapse of these fractures. Initially, we thought that collapse is very useful, but now the studies have shown that uncontrolled collapse leads to shortening of the neck and smaller size of the head, therefore affecting the abductor mechanism. So all newer devices now are being made to prevent further collapse, post-operative collapse, uncontrolled. Dr. Trikha, please.
Right. So can I start,
Okay, so,
Unmesh?
yes, sir. Please, Dr. Trikha, he needs no introduction. Sir, please.
Okay. Thank you, Unmesh, and other people from the U.P.O.A to invite me out here for neck femur fractures. And my talk is to be on dynamic hip screws and how still they are still valid in the present world when Dr. Amit Rastogi has said how new things have come up. So my job is cut out, and I'll start by saying that we all know it's an unsolved fracture, challenging fracture. A lot of armamentarium is available now, as was shown by Sir, but no consensus is still there. Remember, the complications rate still remains the same with most of the implants, which may be avian, non-union, malunion, implant failure, and need for reoperation. All of us, I think, have seen this movie, The Dirty Picture, and there is a dialogue out there. फिल्में सिर्फ 3 चीजों की वजह से चलती है: entertainment, entertainment, entertainment. Bringing that to neck femur fractures, I would say, reiterate the point with Dr. Amit Rastogi said. Only reduction, quality of reduction, and how you can maintain that reduction. That is the important thing in neck femur fractures. Quality of reduction, how to get it, has been told by Amit Rastogi, sir, and how to maintain that reduction. That's what we are going to discuss in the next 3 or 4 talks, which we all are going to speak on. So my job is to why DHS? I would say that it's a simple implant, technically easy to use. Everybody is familiar. It's readily available in remote areas, technically very easy to use, because many of the other things which are going to come after me are going to be technically difficult and not readily available in all the places. Biomechanically, I will show in the best of the literatures that it is one of the most stable implants that you can get in neck femur fractures. Clinically also, it gives us comparable good results. Every ortho surgeon knows how to use a DHS. And if I can say, it's not expensive. In fact, with the newer implants, it's nearly 10 times less expensive than most of all the other implants which we might be speaking upon later. So if I have to give some marks to the DHS, I'll give it 3 to 4 stars based on its availability, technique, stability, results, and the price factor, which is so important in our country. Now let's bring out the literature and the facts. This is the FATE trial which Sir showed. And as he showed, I'll bring out the interpretation of what it was done. It was published in Lancet of randomized controlled trial. It definitely said that hip screws do not have any advantage, but the smokers, displaced fractures, and base of neck fractures might do better with sliding hip screws than with cancellous screws. So that's the conclusion and abstract of Lancet FATE trial, and that's what makes it an important factor, an implant to be used. Coming to another biomechanical study in which finite element analysis between the locking plate, screws, and DHS was there. And they found that in vertical fractures, we are talking of unstable, displaced, and vertical fractures. And this non-displaced fractures, anything you use is going to give you us good results. The problem is in displaced, vertical, and comminuted fractures, which are going to give us problems. And here, DHS with derotation screw. Mind you, that study which Dr. Amit Rastogi showed did not have a derotation screw. Here with derotation screw, it gives us one of the best, strongest structures, lowest femoral head displacement and interfragmentary movement. And then let me bring out Karl Stoffel, the founder of FNS, which Dr. Mukesh Jain is going to say. And in his paper, which he himself compared the FNS with DHS and cannulated screws. And you find out what he has said. From a biomechanical point of view, femoral neck system is a valid alternative for unstable fractures, comparable stability to 2 DHS system. So our old fracture DHS, old Sasta Tikau implant is still holding true with FNS also. Comparable stability to 2 DHS, superior to cannulated screws. What other implants nowadays are doing are taking out the complications of what DHS gives us and combining them into one. That's what I can say. DHS might be a poor man's FNS, which still with a derotation screw can give us excellent results. So when do we use them? We know in intertrochanteric and in unstable neck femur fractures, vertical fractures, posterior caudal comminutions, and basicervical fractures. Mind you, I have not taken out the subcapital one, and they are not so good out in the subcapital, and we know the rotational problem, which I'll dwell on further out here. How does it work? We all know that it's an extramedullary device. We can use two cortical compressions. The angle, the barrel gives us that angular stability, which is so important. The lag screws gives us the compression and mild collapse. FNS also gives us 2 centimeter collapse, whereas the Phase 2 trial showed us that Slobogian showed us that if it is more than 5 millimeters, it's going to hamper the functional outcomes. Even FNS gives us 2 centimeters of collapse, which is there. So let me show the surgical technique. We all know we reduce it first. If we see that it's not good, we get the reduction, and then we start our DHS. We all know how to do it, so there's nothing new. What is more important is to prevent the rotation, especially on the left side, that you put in a lot of K-wires and then make it sure that you are putting in the derotation screws later or initially, depending upon your bone quality. I normally put in 2 or 3 K-wires before and then finally get the compression with the derotation as well. And this is what you can get. You can use, normally available is 4-hole plates. You can use a 2 or 3-hole when it is available and if it is available to you. Look at this word unstable fracture pattern. You get the reduction which you want. And again, the same things, multiple K-wires, which will help you prevent the rotation when it is happening, when you are putting in the lag screw. And that is what is the main thing of complication, or I would say a negative aspect of DHS, which we all need to take care of. Rest, it gives us one of the best mechanical stabilities which one get in a neck femur fracture. You can see that it's not in the best of the alignments. There is slight varus out here, but the stability which is provided by the DHS and the derotation screw, that helps us even ward off the mild and the minor reduction problems which we have in neck femurs, which because it can continue to stabilize the fracture reduction for a very long time. And at the end of 3 to 6 months, you will find that the union has happened, which may not be possible with the cancellous screws or some other implants which we might be using. And that's his reduction, clinical outcome, which we have seen. Even in some elderly patients which are having a BCO with a vertical sort of a fracture, we have been using DHS because this was before the advent of FNS, because it gives us a unilateral single implant which can give us a compression as well as an angular stability. But I can show you that this also gives us good results, provided that you are using it, getting the reduction properly, as I said, and then maintaining it, which and DHS gives you best, if I can say that way. We used a 2-hole DHS out here, and the compression which you get with the lag screw, you can see the compression is so that there is some amount of shearing or overlap, but it maintains the position. And even in late 50-year-old ladies, you can see that finally this is around 15 months of the fracture which we got the X-ray, that it has united and patient is perfectly fine. This is the 15 months, which is there. So why it is not so prevalently used DHS? And that brings us to the complications. People say it's more dissection. I think we are knowing how MIS can be used for a DHS. If we have 2-hole DHS, we can definitely do it from the similar hole or similar incision site equivalent to a CCS. The screw backouts and the collapse of the neck happens also with CCS and with FNS. And I think Ashok is the only one where the collapse is not going to happen, but it also has its own problems, which will be enumerated by him, if I think so. Revision surgery is cumbersome. That's what is the normal excuse, I think, because of the 12.5 millimeter thread diameter. But AVP, when you are reducing and getting a revision surgery, it doesn't have any problems with any of the implants which you are using. These are the common ones. The collapse, which can happen with cancellous screws. You can also have the avian, and that brings us to the avian problem, which is which is given the DHS, I would say, the bad name, but the avian rates are 20 to 23% than that. This meta-analysis done in 2021 has shown that DHS and CS have the similar complications except the avian. And here all the randomized control from PubMed, OVID, Cochrane, all were taken into, and then they have done this meta-analysis and a systemic review. The problem is the osteonecrosis because of the rotation. And that's what, if you see here, the reduction initially was good, but later on when you are tightening that lag screw, that's the time when this lag screw threads of the DHS gives you problem, and that can rotate the head, causing the devascularization and the vascular problems which can happen. So how do we optimize the results? Anatomical reduction, provisional fixation. I would say use fresh reamers, tap before you are putting in your lag screws, especially in young patients. Especially be careful in the left side neck femur fractures, because the clockwise and the anti-clockwise movement which you are going to get, the clockwise in the left side is going to cause the rotational element, exaggerate and exacerbate that. Place the lag screw at the center, just like in other problems, tip apex distance of 25 millimeter or less, and you can definitely use a 2 or 3 hole DHS. So this is what you do when you have reduced it. You put in your guide wires, you put in some of the technique is that you put in the derotation screw first, which will give you the hold, and then you ream and put in your lag screw so that the derotation can be stopped, especially in the left side. And that's how you can get it and prevent the rotation of the femoral head. Or the second way by which you can do is you can put in multiple K wires, thick K wires, 2 millimeters or so, and more than that in all the interior and the posterior places, and prevent the rotational which is happening with the lag screws. One more aspect which nobody is going to say, I would say, in this seminar is the non-union part and the neglected part, which we all see so common in neck femur fractures. No other implant is going to be helpful, which we are going to discuss now, except the DHS, where we can do a valgus intertrochanteric osteotomies. Dr. Ashok Gavaskar has presented his paper, a good paper on this, subtrochanteric one as well. And this is one of the papers which I have taken because I use a angle blade plate, but to confirm and add to my facts, I have taken this paper from AIIMS Bhubaneswar from Chinese journal, and the photographs are also theirs, where they have used the DHS with an intertrochanteric osteotomy for a neglected or a non-union of neck femur, which is also the plus point of a DHS with a derotation screw. So my friends, I'll conclude by saying, that reduction of the fracture neck is the key. Remember those three: reduction, quality of reduction, maintenance of reduction. Various options of fixation might be available. Some may have some plus points, some may not have, but DHS and CCS, along with some augmentations nowadays, have withstood the last 20-25 years of clinical experience, which other implants still are in their childhood or infancy, I can say. Mechanical stability provided by DHSs remains still the best among the implants in vogue, along with the derotation screw. The problem which is there with DHS is the rotation of femoral head during insertion of lag screw, which increases the chances of AVN. And that's the area, if we can counter that, this implant, the poor man's FNS, can give you the best of the results. It still remains one of the very big standard modality for unstable, displaced, vertical fractures, and also in non-union for valgus intertrochanteric osteotomies. Thank you everyone for your patience here.
Thank you, sir. Thank you, sir. Thank you so much for this extensive lecture with your vast experience. I will quickly take up a few questions. I will request our panelists, Saraf sir, Gautam sir, and Kaushal sir, to take up a few questions from the chat box before we move on to the next lecture.
There are some questions in the chat box. What about the DHS and direct fracture presentation? I think Dr. Trikha has elaborated it. He has elaborated the use of DHS in direct fracture presentation. Double angle DHS and DCS is another question. It's been partially touched by Dr. Trikha. I think he can elaborate more on it.
I would say that, sir, in neck femur fractures, in the acute neck femur fractures, the role of double angle implants may not be used because we are not, the angle of the neck and the shaft can be easily maintained being a neck intracapsular fracture. It's only in the fracture patterns where we are going for a non-union or neglect, where we can be using a double angle. But in fact, many of the people are still using the single angle plates and the implants for even the non and the neglected parts, be it an angle blade plate, or be it a DHS or a DCS. I am not a proponent of a acute valgus osteotomy in vertical fractures, so I do not use a double angle DHS.
The dictum for long and short barrel, I think it is according to the length of the screw, compression screw you use, back screw. If it is more than 85, you have to use a long barrel, otherwise short barrel also works. Another question was age cut off for younger patients for DHS or CC screw. Dr. Trikha, your comments on any age foundation or for DHS or CC screws? You are mute.
In a pediatric age group, most of the times, depending upon the fracture pattern, I use screws more because the forces are not that high. If I feel that the fracture pattern is amenable, I will be using a pediatric DHS, which is sometimes available with us.
So you have answered one more question which was there about pediatric use of DHS. Thank you.
Dr. Trikha. Dr. Trikha.
Anji.
After you put screws, would you like to give a spica in children?
I would say that I do not use 4 mm screws in the children normally because the cannulated 4 mm screws have got a tendency to bend. So I have a special 5.5 screws which have been built and which have been built by me. I use them in most of my neck femur in pediatrics. And if I have a problem and I'm not happy with my stability given by my screws, I usually give them a cylinder slab rather than a spica, because that allows the hip not to be flexed because the knee is in extension. And that usually impacts.
And of course, you will spare the epiphysis, you will not cross.
Yes, definitely.
Dr. Trikha, sir.
Sir.
What is your opinion about capsulotomy?
That's a controversial thing. I normally, if I'm getting an open fracture, I'm doing it because it's obvious that in open fracture reduction, we are doing a capsulotomy. But otherwise, I have not been doing it or purposely, deliberately doing a capsulotomy. And I don't think that my results are any worse than anybody else's who are doing the capsulotomies.
Why I asked this, you are absolutely right. This is still controversial. Most of us have realized that while we are drilling the drill holes, and after we remove the drill bit, you see a gush of blood under pressure coming out. So is that already decompressing the tamponade?
Most of the time, especially when we are using the screws, we try to fix it with either sometimes inadvertently also goes into the acetabulum and sometimes deliberately also. So I feel that it can be done. In my that's what I said. There are people who are very big proponents of capsulotomy. I have not been doing it deliberately or purposefully, except in open fracture reductions when I do them.
Dr. Ashok Gavaskar, your opinion on this?
Which one, sir?
Capsulotomy in femoral neck fractures.
He always does it when he's fixing it. Yes, Ashok, please.
I think the pool data shows like capsulotomy might have an advantage in reducing the incidence of AVN, but like as Dr. Trikha said, like if I'm doing a closed reduction, I'm not doing it.
So practically, we are not doing it. It's theoretically more of a theoretical aspect than a practical aspect.
I think the capsulotomy is a two-edged sword. If you don't do the capsulotomy, it causes tamponade. And if you do capsulotomy, you make it avascular. So you have to do a judicious capsulotomy, taking care of both the parts.
Thank you, sir.
And Dr.
I think we should proceed with the next. Okay, sir. Yeah, please. You can have a last question and we proceed for the next. Yeah, sure.
Benefit of listeners. Dr. Trikha, you fixed with multiple K-wires. Do you routinely fix them across the acetabulum or just in the head?
Yeah, it depends. It depends on what sort of and what thickness of K-wire I'm using and which quality it is. I normally, when I'm using a thick K-wire, I set 2 millimeter minimum K-wire if you are going to use. Then you can just transfix it to the acetabulum. But if you are not using, or you're using 1.6, 1.8 or 1.5, and you are getting a rotational of the lag screw, it will be a nightmarish thing if it breaks somehow. and it is a problem. So normally I would go in with up to the subchondral region with a thick K-wire. I'll wait, I'll see when it is happening. The best thing is that you derotate it quarter degree or partially you derotate your lag screw, and you can see that the rotation is getting back. At that time, I will just put in my K-wire, transfix it to the acetabulum, and then tighten it completely and then bring it out. So I will keep it less.
What's the harm in putting 2 mm wires only and fixing it to the acetabulum all the time?
No, you can do that. You can do that, but you have to use 2 mm. Never use your guide wires, which are so commonly available with your instrument box. And that's what we are normally using, or a thin K wire. Because if the rotation happens and you're not, I have got many 2 or 3 episodes in my life when my residents in the morning X-ray have shown me. And I'm just hoping that it is not in the acetabulum, it has gone inside.
I use 2.5 or 3 mm K wires.
Yeah. Thicker K wires will always be helpful.
So I think with that, we'll proceed to the next lecture because we are running short of time. So I would like to invite Dr. Ashok Gavaskar. He's from Chennai and he's got a vast experience and he's a very active member in AO as well as he's an editor in the IJO and is also a member of AAOS. Over to you, Dr. Ashok.
Thank you. Thanks, Unmesh, for the invite and also U.P.O.A. And I'm sorry that there might be some repetition with the first talk, but bear with me. So I'll speak about my experience and also about what the literature says about medial buttress plating for Pauwell's 3 injuries. So if you look at this one, young 29-year-old male who has an intracapsular fractured neck of the femur on the left side, you can see eye verticality of it, classified as Pauwell's 3. He's got no other injuries. And this guy, and this is the preoperative CT of that guy. You can see the fracture angle here much more clearly and also some evidence of comminution superiorly and posteriorly. And this is what was done. Like, so I used a direct anterior approach through the uter interval, did an open reduction to get anatomical reduction, and then used compression from the got compression from the lateral side implants using a partial threaded screw, and then converted that into a length stable construct using a fully threaded lag screw, 6-5 screw. The question is, like, you can see a small 3-5 pelvic reconstruction plate sitting anteromedially. What does that do exactly here? Is it a reduction tool for such fractures, or does it help to enhance stability of the overall construct, or both? So that is what we will look into as in this lecture. So if you look at the conventional constructs used for a Pauwell's 3 injury, we have the parallel neck screws. Of course, the main limitation of this construct for a Pauwell 3 injury is that, of course, they are not perpendicular to the fracture plane. But to me, the major limitation is that when you use parallel screws for a Pauwell's 3, there is no calcar for the screw to act as an effective buttress. What I mean is the inferior calcar screws. So in a Pauwell's 3, the exit of the fracture inferiorly is almost in line with the left set. So when that happens, like, the inferior screws lose their advantage to act as an effective buttress against virus. And it is subject to tremendous amount of cantilever loading and will fail with time. So they are not the best construct to use in a Pauwell 3. So what about offsetting this with an off-axis screw, which is nothing but a screw which is not in the axis of the femoral neck, but placed perpendicularly or more or less perpendicularly to the fracture plane. This has been shown biomechanically to improve the stability of the overall construct in a Pauwell's 3, but of course, this has never been shown in a clinical paper. To me, as Dr. Trikha said, like, the best possible construct, a conventional construct, I'm not including the newer ones like the FNS or the fixed angle systems, but the conventional construct, I think, is the DHS, and then couple it with a screw so that at the end of it, you create a length stable construct whereby you achieve all your compression on table after an anatomical reduction. And then you do not want the fracture to collapse, because in a Pauwell 3 with a laterally based construct, it is very difficult to make sure the collapse that happens will be controlled over time, because the fracture angle is just not amenable to that. So at the end of it, you should have an anatomical reduction and a length stable construct. So I think a sliding hip screw with a length stable screw provides the best possible construct. So if you look at the current status of these constructs in a Pauwell's 3 injury, there are still concerns of eye failures and even non-union. Why? Probably because none of these constructs that I told you before is able to resist shear adequately. We do know that Pauwell 3 fractures, because of their verticality, is subjected to a tremendous amount of shear forces. So any construct that you use in these injuries should also be able to resist shear. So this was a paper from Frank Lipporaci, which looked at these constructs specifically in the Pauwell 3. They compared cancellous screws and the sliding hip screw. Both constructs were length stable in 62 patients. And in their study, they found out the failure rates or non-union were still pretty high. Of course, the sliding hip screw fared better than parallel screws, but this failure rate of more than 10% is still definitely shows that like there's a lot of scope for improvement. So how did the concept of medial plating came into vogue? This was a brainchild of Corey Collins and Azan Mir from North America, this was the first paper on the topic in 2015, where they published their biomechanical study, where they showed that when you can position a plate at the apex of the fracture, it will obviously resist shear forces better. So if you can kind of put a plate on the anteromedial aspect or anteroinferiorly in anti-glide or buttress mode, this might be a solution to resist shear effectively in a Pauwell's 3 injury. This has been kind of used over last 5-6 years in many biomechanical and clinical studies as well. So what does the medial buttress plating require? What is the feasibility of it, doing it in every case? The major limitation to me is it requires an open approach. The question that I have to answer myself is like, is this a technique that gives me such a big advantage in terms of construct stability or as a reduction tool that I need to do an open reduction for every fractured neck of femur? I don't think I have a clear-cut answer to that right now, either based on my experience or on the overall literature that on the topic. But what we know is, if we can do an open reduction, it often improves our ability to achieve an anatomical reduction, which has been shown to be an independent predictor in predicting outcome after a femoral neck fracture fixation. These are images taken from the AO trauma webcast in 2020. If you can look at, they have replicated a Pauwell 3 injury here, and these are the reduction images, that is close reduction images. And it's quite easy to say that like it is quite tempting to put a couple of screws or a DHS from the lateral side because the reduction seems pretty good on these ones. But once you open up, this is what it looks like. You can see the anteroinferior apex with a lot of displacement. And this is what happens a lot of times in the clinical scenario as well. Our ability to predict anatomical reduction by fluoroscopy is often limited, and open reduction definitely improves our ability to achieve an anatomical reduction. So how do we go about it? What approach we use? As Dr. Amit said, like there are 2 ways to do it. Smith-P, I prefer a Smith-P compared to a Watson and Jones. To me, like it sort of gives me more space to work. And it also gives you much better access to the fracture apex, which is much more inferior in these fractures. So we take down the direct head of rectus tendon and then do a capsulotomy and go ahead and do it. But the disadvantage is it needs another approach for lateral fixation, but I don't feel that's a huge disadvantage. The main prerequisite is like a medial plating without anatomical reduction makes no sense, because like whatever implant or instrumentation that you're going to add, you require an anatomical reduction. So when this medial plating helps is like when you can get an anatomical reduction, especially at the apex, and then if you can buttress it then it might possibly improve your stability of a construct tremendously. So you need to achieve an anatomical reduction. And in fact, like whenever you are aiming for a length stable construct in these fractures, whether you use a medial plate or any other construct, I think it is important to achieve an anatomical reduction, so that because the fracture is not going to collapse anymore, you can't leave gaps, you can't leave step-offs here. And when you position these plates, don't try to fix them on both sides. Try to get a hold on the distal fragment. The plate will effectively act as an anti-glide right now. You can still achieve your compression from your lateral based implants. And at the end of it, you can decide whether you want to add a few more screws into the proximal fragment or leave it like that. So I'll just take you whatever I said, like through a case, which was actually my first case, which was done around 3 or 4 years ago at an outside hospital for another consultant. Like this was a young male who was reported to an ER after an injury on the same day. This is the fracture that you can see. You can see pretty significant amount of comminution on the femoral neck fracture on the left side. And this is what the CT scan looks like. Some of the relevant CT images, the axial ones. You can see the retroverted femoral head. You can also see some posterior comminution. And as I said, my first go-to is to attempt a close reduction. And this is what it looks like on a fracture table with 20 degree of internal rotation. As you can see, the AP looks reasonable, but on the lateral side, there is still a fair amount of retroversion, which is still not corrected. So at 50 degree of internal rotation, this looks pretty reasonable right now. And I think it is ready for instrumentation. But don't stop with this. Take your CM through a few more angles, and you will often find that the apex actually is not anatomically reduced as in this case. So the plane of the fluoroscope may not be really finding out the relevant displacement patterns in this injury. So it is important to do a thorough fluoroscopic examination before you commit to do instrumentation from the lateral side. So we went again with Smith P. Open reduction was done. You can see the small old 2-7 tubular plate on the anteromedial aspect. As I told you, screws only in the distal fragment. Now the plate acts as an anti-glide device. You can see screw 2.8 guide wires across the fracture side. You can also see a Weber clamp clamping it down. So once the reduction is satisfactory, as you can see here, I have driven the 2.8 guide wires across the acetabulum. I do this because we had a discussion on this just before the talk. I drive it into the acetabulum if I'm going to use a DHS on the lateral side as the device to achieve compression. So in this case, like I had planned to put a DHS on the inferior side, and on the superior side, a fully length threaded 6-5 screw because it was comminuted superiorly. So if I'm going to compress it with a DHS, then it's probably better I drive these wires across the acetabulum because it can really spin like crazy when you are reaming it and putting your latch screw in. So the screws guide wires across the acetabulum, and this is how we do put them anteromedial plate. These are images from a colleague from Denver, Dr. Cyril Moffrey. Like you might have to get the limb into pretty big amount of external rotation to access the medial side. But I can tell you that you do not have to be really, really inferior or medial. Dr. Amit did touch about this. You just have to stay at around like 5 o'clock. It can be anteromedial because the most of the time the Pauwell 3 apex is not exactly inferior. It's more on the antero-inferior aspect. So you may not require this kind of external rotation all the time. So, and once you are done, like this is what it looks like. The only problem with this is like there is a lot of implants inside, like so there could be a lot of crowding. As you can see here, the DHS latch screw is not in the perfect place, and there is also possible breach of the posterior cortex with the posterior 6-5 screw. I didn't follow up this patient actually, but because this was it belonged to another consultant. But of course, like I don't think we had any problems with this. And as you can see, the 4-hole medial plate with screws only in the distal fragment. And this is what it looked like. This was the final fixation. As you can see, reduction is reasonable considering the combination we had. A small tubular plate, compression through the DHS latch screw, and then we maintain that length by using a couple of fully threaded screws. So what does the literature say about the use of augmentation medial buttress plating? Biomechanical studies have shown that if you can use an augmentation plate either with cancellous screws or with the DHS, it does increase the stability of the construct. There are a few clinical case series as well, but nothing prospective comparative so far. I have used it in 7 cases, like 5 of those patients are mine who still had a follow-up. We didn't have much problems, but early days yet. This is another patient whom I did recently, a 42-year-old male, a polytraumatized individual. He had a shaft femur, shaft tibia on the same side as well. And he also had a posterior wall acetabulum and another shaft on the other side. Head injury too. He was hemodynamically stable. And this is the X-ray. And my initial plan was to sort of like think about a retrograde nail for the femur, but I thought the fracture comminution was extending a reasonable, quite proximally. I thought like, can I get this with an antegrade nail? So I thought the neck won't be that difficult, but when I put him on traction, this is what it looks like. I could have probably used an external fixator or a femoral distractor on the shaft. That would have probably helped me to derotate the shaft fragment a little bit better, because with 45-degree internal rotation, I was still not even close. But I just thought of going again with an open reduction. And my plan was to do a Smith P, use a medial buttress plate for stability to resist shear, and then a long cephalomedullary nail. And this is what you can see, the fracture apex there, antero-inferior apex there, pretty much displaced. And this is how it was reduced. Shank spin again into the distal fragment to internally rotate it more effectively because it had a discontinuity distally. Another shank spin into the proximal fragment. Once and also a bowl spike. Once reduction is done, you can see I place my wires carefully on the anterior side so that I can place my cephalomedullary nail as well. And then once I was satisfied with my reduction, I go again and then get my nail in, and finally my anteromedial plate to improve the stability of the construct. And this is what it looks like immediately. And then at 3 months, at 10 weeks post surgery, his fracture shaft is still not uniting. Something needs to be done for that. Another case, a young male with again a neck shaft, high energy injury, again a Pauwell 3. Again, in this case, like it was pretty straightforward for the shaft. I thought like, so we had pretty good real estate. So we went again, did a retrograde nail. And actually this case was initially came in the night where another team did this, splintered the shaft fracture and then fixed it. Fixed the femoral neck after a closed reduction. As you can see, it was not a great reduction. The comminution didn't allow them to get a great reduction, and this is what the post-op CT showed us. So I did a revision on this actually. So open reduction, and then we went ahead and used a 3/5 1/3 tubular plate. Not the best position for a plate because this was slightly more anterior, but not exactly infromedial, and this is at 6 months showing an uneventful outcome. So what are the concerns with medial buttress plating? You have to understand that this is an intracapsular implant. So do not use too long a plate, preferably a 4-volt, not more than that is often required. Yeah, if you can use a 2.7 plate, it is great. 3.5 isn't bad either, but make sure you position them correctly so that you don't create impingements. There are reports that intracapsular medial plates can lead to femoral neck, the plate impingement on the acetabulum. And also make sure you keep your plate at around 5 o'clock. Don't have to go really inferior because you might interfere with the inferior retinacular arteries, as Dr. Amit pointed out. So in summary, medial buttress plating is an interesting concept. It's biomechanically sound in Pauwell 3 injuries because of its ability to resist shear forces much better than any other implant that we discussed. It's anatomically viable because it is not a difficult technique. The anteromedial portion is pretty good for plating. And in terms of interfering with the vascularity, I don't think it matters much, but it needs an open reduction, and you need to sort of like weigh whether you need it just to add a medial plate or to improve your reduction. I think like my take would be like, if I need to improve my reduction, I'll open it and probably add a plate as well. And you also have to remember that this is not a standalone construct. You need to use it always in combination with more robust lateral based implants. So this technique is promising, but it needs further control based clinical studies to validate it. Thank you.
Unmesh, hello.
Ashok,
Are you going for next lecture or the questions?
Ashok,
Yep.
Can I have one question?
Yes, sir.
What's the position of patient when you are doing it? And especially when you are doing it with ipsilateral shaft femur, do you use a traction or a plain top? Because you cannot use an SP without traction table.
Yes, I agree. As you said, like if you look at the first case that I showed you, like that was the patient being supine on a normal table without any boot traction. Like we put him on traction, but when we knew that closed reduction is not working, we just shifted him to a regular table with assistance to help us with manual traction. And when we put the implant, we sort of like bring the leg more into a external rotated flexed position so that you can access the anteromedial side. But if you look at the other case, the cephalomedullary nailing case, like I did that on fracture table actually. So, and if you can look at the plate positions compared to the first one, the one on the cephalomedullary nail case, it wouldn't have been exactly on the antero-inferior or the medial aspect. So I think like it based on the CT image preoperatively, if I think the fracture apex is not too inferior that I need to go really medial and buttress it, I don't mind actually putting them on fracture table as well, because I'll just relax the traction a little bit, bring them into a little bit of flexed and external rotated position, and then I can do an anteromedial plating without difficulty.
Dr. Ashok, there is another question that do you always use fully threaded screws in inferior quadrant with or without plate?
It depends, and it depends. Like say if I'm using DHS as my mode of compression, then it's almost always a fully threaded lag screw to complete fixation, because like I need to, because DHS will still allow the fracture to collapse. So I need something that will not allow that to happen. So I make sure I use more than one screw, because if I use one screw along the axis of the same thing, like if it's a partial threaded screw, it is not going to work. So I will use a fully threaded screw, either in the same plane or in a different plane, or add another screw as well. If I am going to use screws as the only mode of construct or as a mode to achieve compression, then it will always be a partially threaded screw first where there is no comminution. It's either inferior or either superior, depends where the comminution is, and then complete it with a fully threaded screw to make it length stable.
I think that's right. Another question is weight bearing protocol. Is it different when you are using the augmentation medial buttress plate?
I don't know, like possibly, like I don't know whether like whether I use an augmentation. There are proponents of proponents for early weight bearing, irrespective of whether you use an augmentation plate or not. I know guys who allow patients to weight bear as tolerated with a DHS and a derotation screw for a femoral neck. But I don't know, like because I don't do that. I wait at least 6 weeks for them to get my first follow-up X-ray, and then think about progressing them in terms of weight bearing. And this is regardless of construct that I've used in my practice.
Then the question is, does the anteromedial plate help to prevent posterior comminution collapse? I think that's a good question.
Yeah, may not. In the sense, like what you can see is like I feel the anteromedial plate is really useful when you have antero-inferior comminution. In fact, like a lot of Pauwell 3s have antero-inferior comminution. Like that is probably a great place to put an anteromedial plate, because like it effectively buttresses the calcar more really well. And even I don't think it might help to sort of tackle posterior comminution. I'm not sure how that will help. I'm not really sure.
Do you have any suggestion if there is a gross posterior comminution? How will you approach?
Yeah,
Look at
I
this
think
way.
like yeah, I think approach doesn't matter. Ultimately, like you need to open reduce, do a if you have a lot of post-medial comminution, debride the area and look for the anatomical reads. Like forget the comminuted area. That is what the entire principles of fracture reduction is all about. So there will be reads, there will be cortical reads where you can get an anatomical reduction. You also have to be really careful about clamp application when you are dealing with a significant amount of posterior comminution. So, so always look for anterior cortical reads and then try to sort of achieve compression across that zone, stabilize that zone first with whatever implant that you are going to use, and then think about bridging the zone of comminution at the end.
Can I add, Ashok, on this particular aspect
Yes.
of posterior comminution? I think for posterior communication, we are worried about that undue collapse, which we do not want in fracture neck of femur, which leads to varus and further non-union.
Right.
So with DHS, once we are putting in completely threaded 1 or 2 6.5 screw, then adding up another plate, so we are further adding to the stability. So probably we are already avoiding that sort of collapse which worries us for the posterior comminution. As such, posterior comminution, we are not worried about that we need to put back those fragments and really do any augmentation there. So if I see the biomechanically, DHS with add on another 1 or 2 screw and add on medial plate, it becomes a very stable construct. So we may not need to add anything further for the posterior communication. That's, I think, which works biomechanically.
Yeah.
So
Yeah.
probably there are no
My,
such
my,
studies which says about this.
yeah. Might be possible. Like as I said, like very limited experience on this. So like I won't be able to sort of like vouch for it. But like if you're going to use DHS, a couple of 6.5 screws, and then an anteromedial plate as well. And if you're going to use screws into the proximal segment, it can make it really crowded, and you might find it really difficult to kind of negotiate the preferred zone. So in those cases, what I do is like I don't nowadays like I don't put any screws through the plate into the proximal segment. I keep it as anti-glide if I use it as a reduction tool. Then at the end of it, once my DHS and the screws are in the right place, then I can always negotiate a couple of small screws into the proximal fragment if I think I have comminution at the inferior area, which I need to bridge it. Otherwise, I just leave that like an anti-glide construct.
Thank you, Dr. Ashok. We'll have more questions at the end of all the 5 lectures because there are plenty of questions. And I invite the next speaker, Dr. Arun for his BDSF.
Is that visible?
Yes.
Well, I'm in pretty august company, I'll say. Definitely. And I'll thank Orthopaedic Association, the members, and all the dignitaries of the U.P.O.A for having me here today. Thank you so much. I'll, of course, be talking again on the Bdsf technique. That's a relatively new aspect of the fixation. Back in 2011, Filipov had first established this. And getting out of it, as our speakers or illustrious speakers earlier have been telling, various methods of fixation by screws and DHS and whatnot. And I think we do need a new technique because we all do agree that they are generally associated with at least 20 to 42% of failure cases, of course, depending on the various aspects of the fracture anatomy, the patient itself, the osteoporosis and whatnot. And of course, the biomechanics of the earlier conventional 3 screw placement of multiple screw placements concerned. Generally, we've been having high failure rate in conventional screw fixations because of the lack of stability of the construction regarding the varus stress, number 1. A lack of a stable sliding phenomena. It does slide, but it toggles. It toggles in all directions. And the reason for that is because of the inability to move the entry point of the screws distally into the solid diaphyseal cortex while simultaneously positioning 3 parallel screws. Because you don't want to go too far down, you do want a diaphyseal attachment in one part, but you don't want to, because once you have gone further down and you increase the angle of penetration, the surface of the femoral neck cross section decreases geometrically, and practically the placement of more than 1 or 2 screws is difficult to accomplish. And of course, 2 screws don't do the trick. So an original concept of a method of screw fixation of femoral neck fractures in osteoporosis, establishing 2 supporting points for the implants and their biplane positioning in the femoral neck and head was brought on by Filipov, and this he first published in 2011. What's unique in this? Well, the placement of the implants. The BDSF method shows that the 3 cannulated screws are placed in a frontal plane. The plane at a highly increased angle, at least one of those screws is at a highly increased angle. Both the distal and the middle screws touch on the curve of the distal femoral neck cortex tangentially. And on the AP view, you see a F being formed, and that is why it is also called the F technique. On the lateral view, you see that the 3 screws placed are in 2 vertical oblique planes. This is on the lateral view. So this is why you call it biplanar. The 2 planes diverge from each other in the direction of the femoral head and are oblique towards the frontal plane. Right? You get my point? And the distal screw is laid in the dorsal oblique plane, the distal screw. And the middle and the proximal screws are placed in the ventral oblique plane when the patient is lying down. For the conventional methods, the static analysis, well, this talk is more on the biomechanics rather than just 2 elaborate talks as we've been having Dr. Ashok and Dr. Trikha and everybody talking about it. So I would rather be discussing more of biomechanics in this. So the earlier conventional methods of femoral neck fixation by the 3 cancelous screws, this entry point of the 3 screws are placed in thin cortex of the greater trochanter or very close to it. So you have the screws often located in soft cancellous bone. The bone is osteoporotic and it is near the axis of the femoral neck because you do want it in the axis of the femoral neck more perpendicular to the fracture line. There is lack of solid support points. That is why this would act as a beam in an elastic foundation. And the elastic foundation is realized by the cancellous bone. You realize that the beam, there's a beam lying just in the center of a muddy part or sand, and you place a structure on one side. It is going to toggle in all directions. It's going to slip on both sides. It's going to tilt on maybe that is the varus and valgus and anterior posterior directions. And you certainly don't want that as fixation methods in these particular region. Well, both of these problems are resolved by the BDS screws. The method, this concept of biplane position of the 3 screws at an obtuse angle. You see the lower screw is a very pretty obtuse angle. The provision of 2 steady supporting points for the implants and the obtuse angle at which they are positioned allow the body weight to be transferred successfully from the head fragments onto the diaphysis. These are distributed very well. You have a support point in the center and you have 2 support points at least in the diaphyseal part, and the position of the screws allows them to slide under stress at a minimal risk of displacement. You realize that the screws are placed in a biplanar fashion on the ventral part and they are both resting on the calcar and the diaphyseal. So even if they do need to collapse, which is pretty well minimal, they are controlled in all directions. I'll be talking a little more on the next slides. The BDSF method in the implant is additionally supported at points A and B of the cortex in such a way with BDSF method. Model is assumed to be a simple beam with an overhanging end. This, what I would want to tell you is like an overhanging end. Agar aapko main bataun like what we would have structures in our house, the earlier structures when we saw, the girders would be lying and the top upper storied wall would be placed at least 3 feet out. But that would only be possible if the fulcrum arm is short and the lever arm is long. So here you have a lever arm that is the point A on the calcar and a longer arm over here within the diaphysis at a ratio of at least 1:3. So that pretty well supports the whole head, and this is what you want. The advantage is that due to the increase in the distance between the two supporting points, the weight borne by the bone is reduced. That is the end. You ensure that when the weight is being transferred, the tensile forces spread over a greater surface of the lateral cortex, thereby decreasing the risk of the stress fractures significantly. You do not have stress fractures in this particular subtrochanteric drilling parts, which you are prone to be having generally. The advantage with the BDSF is also that the screw placed at a highly increased angle works in a direction close to the direction of the loading force. That is the vertical force, is the loading force in this, which guarantees better result for the screw in its role of a beam because of the influence of its sagging decreases. So you have a load bearing which is taking it vertically, and you have it lying posteriorly so that it does not go from varus, and that is allowing avoiding varus. It is avoiding a posterior tilt, and that's why it works better. And of course, the achieved results for the BDSF method in terms of fracture consolidation are far more successful than the results of the conventional fixation method as found, because they have shown reliable fixation, early rehabilitation, and of course, one nightmare for all of us orthopedic surgeons. You do up a case and he walks in early, and then he says, you tell him not to walk, or you tell him to do something, and the patient is walking in. Yeah, I've been doing it for the last 20 days. So this is, of course, again, another helpful pattern over here, that the patient can walk earlier. Looking at the operative technique, you require 6.5 self-tapping cannulated screws. The core diameter is 6.5 self-tapping cannulated, and an armamentarium of longer screws. That is for sure. That is ranging till a place 145. And I have placed 145 screws
Please mute
myself.
Please mute the non-speakers. All the non-speakers are requested to mute themselves.
Even in Filipov, he had quoted as 130 millimeters as the average length of the screw that was placed over there. Of course, what is mandatory is a good reduction, as all our speakers have already been telling. That is the first solely anatomical reduction is acceptable. You have to get it in a little valgus. The approach is very simple, as in any of the lateral approaches. Starting at the level of the lower end of the greater trochanter with a distal length of about 6 to 10 centimeters, stripping of the periosteum of the lateral diaphysis till about 6 to 7 centimeters. Firstly, we lay the guide wires. Now we go for the steps. We lay the guide wire for the distal cannulated screw first. Tip is placed 5 to 7 centimeters distally. The starting point is 5 to 7 centimeters distally from the base of the greater trochanter, in the anterior 1/3 of the surface of the stripped out diaphysis. And this is directed about 150 to 165 degrees towards the diaphyseal axis, with inclination from anteriorly coming distally to posterior proximally, so that after it touches on the curve of the distal femoral neck cortex, tangentially the wire goes into the posterior superior quadrant of the femoral head. The middle guide wire will come in next. And this is entry is 2 to 4 centimeters proximally from the entry point of the distal wire in the distal 1/3 of the stripped off surface of the diaphysis. The wire placed at an angle of 130 to 135 degrees towards the diaphyseal axis. Inclined from posterior, you start posterior from here. The entry of both the first and second screws has to be a little posterior. The third one has to be a little anterior, because you want to go anteriorly into the anterior part of the head in both the first and second screws. And this has to be inclined from posterior distally to anterior proximally, so that after it touches on the curve of the distal femoral neck cortex tangentially, the wire goes into the anterior inferior quadrant of the head. The last, of course, is the proximal guide wire, 1.2 centimeters proximally from the entry point of the middle wire in the dorsal 1/3 of the stripped off diaphysis, and close to the beginning of the trochanter. This is placed parallel to the middle wire. These two screws are the compression screws. Like, this is the clinical picture of what you would want the patient to be having. The guide wire number 1 and 2, the entry points are posterior. The guide wire number 3, the entry point is anterior. The steps of screw fixation. You over-drill the holes in the lateral cortex by using the 7 mm granulated screws in both the second and the third, the middle and the distal screws. The distal screw hole takes a pretty long time in making. You need to be very careful of that. You need to make it very oblique, use it very slowly, drill it very slowly. The middle and the proximal screws are placed first because they are perpendicular to the fracture surface. Release the foot traction and a several time impaction of the fractures with an additional tightening of the screws. Now this is very important. This was converted a little later when he had brought on a little later that. So this impaction is a must. Finally, the distal screw is placed. This distal screw is actually more of a beam screw. It is more acting like a beam screw. There is no iatrogenic subcontracting fracture, as people were skeptical about earlier. Filipov again revisited. That was an and he published his views in the American Academy of the Orthopedic Surgeons in 2019 with a few more additions, and that is it reiterated that the constant fixation strength is provided during various patient activities. Immediate full bed bearing is possible after surgery for patients older than 55 years because you are able to impact better. The interdigitations fall by better, and you are getting a very good compression with both your screw number 1 and 2. The inferior screw acts as a console beam. It is not a lag screw. So here, the importance is you do not place a washer over here. The first and second screw will have a washer. The third is just as a console beam. You just want a short thread which is placed in the right position. There is no screw in the central femoral neck zone in the lateral view because one that is biplanar, posterior and anterior. The inferior screw should always be placed posteriorly. The middle and the superior screws are always anterior. There are contraindications. You do not want the patient with Pauwell type 3 which have an inferior combination. And for fractures which are starting in the mid-cervical line. You do not want to be operating on patients with very late diagnosis, and especially patients older than 55 or 60, you would rather go in for an arthroplasty. If you have a fixation failure earlier, no, this is a no-no. A small femoral head in elderly patients over 65, you would rather go in for an arthroplasty. If there are pre-existing pathological effects that have hip joint, then you do not want to be working on this. 2 or 3 more important points. Of course, your experience will come with time. The importance of the location of the screws, entry you have just noted. The number 1 and 2 are placed in the position of posterior and going anteriorly. The third one is placed anteriorly, or maybe sometime the entry has to be a little middle in the middle zone of the shaft, because at times you see that the patient has a little more anteversion of the head neck. So in that case, you do not want to be entering too far ahead. You want to be very clear of getting your screw very clearly on the posterior part of the head. The importance of the cortical screw support at the calcar for the third one in the posterior and for the second one in the inferior part is a must. The third hole for that, you need to drill very slowly, otherwise you're going to cause bone necrosis. We'll get on to a couple of cases. No comorbidity with a 65-year-old. Well, I'll say something like a 50 to 55 degree Pauwells. The reduction is paramount. Wires in place operatively. A post-off using a nice V on the lateral and F on the anterior. 45 days, 2.5 months. At 6 months, pretty well united. Don't think there is any head avascularity. The shape is very well maintained. There's a video. I don't think there is any reason for not to be working. Anyway, they're just showing the patient walking. Well, this was a renal and a hepatic compromised case, 40% ejection fraction, a diabetic since 20 years, a 74-year-old male. A very stiffly perpendicular grade 3 Pauwells. Would not want to go in for a prolonged arthroplasty in that. It was in place, so I decided to go in for screw fixation. You see the nice lying back on the posterior cortex, the anterior entry, the inferior calcar support, follow-up 2 months, 3 months, 6 months. I hope this works. This is again a patient walking. screen sharing. I think during the screen sharing, this video doesn't work. Anyway, this was just a recent video. This was the type that I told you, the drag addict type and the and the nasty behavior types who would walk in when just do what you don't want them to do. A 50 to 60 degrees Pauwell. For obtuse, good reduction, screws in place, follow up for 2 months, 3.5 months follow up, 6 months and 10 months. Pretty well united. Well, that's where I rest my case. Thank you.
Thank you, sir.
Thank you.
Thank you, Dr. Anup. Thank you, Dr. Kapoor. Very nice talk.
Thank you.
Very interesting. How many cases you have seen that the long distal screw gets bent? Does it bend? Does it collapse?
Definitely. That's a very good point. That's definitely very good. That means you have been going through all this. If it bends, it does well. If you try to put it a little too far down, you definitely get a nice little bend. It gets a nice little curve. I think the curves all orthopedic surgeons enjoy. And the third screw that goes in, when it takes a good settlement on the calcar, it comes onto the posterior and the superior part of the quadrant of the head. It does bend. If you put in a short screw, it does not.
Now there is a second question.
Yeah.
If there is a lot of comminution on the posterior side,
yes.
So once you put this screw, the longer distal screw from anterior to the posterior side, then does it get support from the bone?
Oh, definitely. Why not? It's going to get supported on the calcar. It is going to get supported on the stronger part of the diaphysis. It is going to get support on the calcar. It is not going to allow it to tilt posteriorly. That is why this type of B.D.S.F fixation does well in posterior combination fractures. In inferior combination fractures, it's not very well propagated.
There is another question.
And then just to continuation of this, because of the biplanar fixation, the two anterior screws are also allowing the tilt to be negated on the posterior part. So you have the biplanar fixation which is avoiding that.
There is another question from Dr. Kaushal. That is there any role of the washers in the proximal screws?
Yeah, definitely. In the screws number 1 to 2, the washer is going to act like a mini plate. You definitely want very good compression over there. So once you want a good compression, you don't want the head to be sinking inside when you are compressing it, because you're going to do it in osteoporotic bones. The first is just lying in thin cortical part of the trochanter. The second is you can avoid, but if you are placing a washer, it is going to act as a mini plate and the compression is going to be definitely much better. The third one does not. Third one is not propagated. You should not do it.
Okay.
Can I, sir? Can I?
Please, sir.
A very nice presentation, Dr. Kapoor. I would like to have the opinion of the house as to how many of you are using this technique. We at Agra are using it very, very frequently with quite satisfactory preliminary results. All of us are doing it at Agra. So I would like the opinion of the house as well. The most important aspect of Dr. Kapoor's presentation is the placement of screws. As he mentioned, the beam screw goes into the posterior aspect and the other two screws in the anterior aspect, so that in the lateral view you have a perfect V. Unless you have a perfect V on the lateral view, your screw placement is not good. So I would like to have the opinion of the house, especially Dr. Mukesh Jain, Dr. Ashok Gavaskar, Dr. Vivek Trikha, about their view on this, because we at Agra are doing it quite frequently.
Dr. Srivastava, I have no experience. I've never done it, so I can't comment on it.
I have not done it either, Dr. Atul. Sorry.
So I would like to ask you, are you inspired by Dr. Kapoor's talk? Would you like to try this?
Definitely, it's an evolution. You see, we are looking for an evolution. We are looking for a solution. So this is one way to have a solution for it. All of these things, yeah.
The results coming from stalwarts like you would add to the data.
Yeah,
definitely.
Dr. Atul, hello. I have read this article so many times because I like it so much. It is so convincing. It is absolutely convincing, but I have not used it. Just maybe afraid of the technique over there. But otherwise, I tell you, it's fantastic.
Sir, do use it, sir.
It's so good.
I recommend to use it. Unless you use it, you will not know the pros and cons of this technique.
And Agra is the leader, I know. I think Agra people should go to different places for a workshop and demonstrate to every one of us so we can use it. It's a wonderful technique, I tell you.
Since you are convinced, sir, I think you should definitely be going for it. It is definitely giving wonderful results. And particularly the case that I have one failure, but I had a frank failure. And that was a case of very heavy lady. It was more of a cervical type of a fracture. And I had placed screws over there. The reason was the patient was very cooperative. I was a little scared. It was in my early days of fixation. I had asked the patient for not weight bearing as we used to do earlier. Let the callus form or let the fracture unite a little bit, and then we'll do something. And just because of the late walking and late weight bearing, that patient failed. And the patients who have been brash, the patients who just walk in when you tell them don't do this and they walk in, they do the best. That means if you have done your steps right, and the patient, this implant is forgiving, definitely. And you want early motion, you want the fixation right, you have placed your screws right, you will definitely get very good results.
Thank you.
So what is the weight bearing also? May I ask you?
I started 20 days partial weight bearing, supported weight bearing, and that will be continued, supported and partial till about 2 to 2.5 months.
And any age cutoffs?
Over 60, immediate. Because you have already tapped, the interdigitations have already settled in. And you have compressed.
Filipov has done this till the age of 90 also.
Yeah.
So
you are able to do it in younger patients also. But there, the interdigitations are not going to settle down very conveniently on the table. You want it to be more weight. You want to delay the weight bearing for about 20 to 25 days, and then more of partial weight bearing, crutch walking with younger patients.
Can I add Arun, something on this? Dr. Ashok, can I take your attention to this particular technique because of two reasons which we were discussing while you were presenting. One is the buttressing the apex, and the posterior combination. So the inferior posterior screw perhaps takes care of both the things. Perhaps it appears to me in this technique. The only apprehension I have personally looking at this, the quality of implant has a lot of bearing on the further stability of this construct, because the screws are pretty long, I think 110 or so, or maybe longer than that.
No, the long screws, you have a minimum of about 120 to 125, ranging up to 145.
So
I have placed 145 degrees and 135 degrees, 125 degrees in the third screw.
So but the load coming on that inferior screw is axial load.
That is axial load.
So it bears. That's it, no?
Yes.
That's the beauty of this.
And the weight distribution has been done by all the three screws.
High, as we see.
Yes, exactly. Right, sir. You are very right.
So do you agree, Ashok, with me that probably it takes care of those two things or not? I mean, it's just my apprehension.
Possible. Anup, like just the thing is, like I have no prior experience. Probably like if you guys do so much volumes on this, like I think we can probably like compare it with the parallel screw constructs for some specific fracture patterns to sort of like think whether I don't think is there a comparative study on this one. Like I'm not sure. Like so. Probably we can think about, because like I think like whatever said and done, we don't get more than 5 to 10 femoral neck fractures a year. The young ones, I mean, and not the old ones, the high energy ones, I mean. So those are probably a great way to do it. But as I said, like as you said, the theory looks fine to me. Yep.
I think
Ashok, that has really reduced the amount of compression, the collapse at the fracture site. And the advantage of that beam screw is that it is more in the line of the weight bearing of the axis, weight bearing axis.
Do you guys use it for Pauwell's 3 as well, the vertical shear ones?
We have tried, but we had a failure, but we try and avoid. Pauwell's 3 we have tried and we have succeeded sometime, and we have failed also. So, but we won't recommend right now for Powell 3 because that is area where we should try and avoid this technique.
So I think we should
Maybe
proceed with the next lecture.
I think we should, yes.
Yes.
Yeah.
We can add with Dr. Ashok's technique.
Yeah. So I would like to welcome Mukesh Jain sir, and with his vast experience, I know he will be just fascinating us with this new technique of FNS. Over to you, sir.
Thank you. First of all, I should congratulate all the 4 faculties, especially Dr. Trikha, Gavaskar, Rastogi, and Arun Kapoor. They have presented so well that I think all the information of the fracture neck femur are now absolutely clear to almost everyone. So my topic is only FNS. We have already seen all the evolution of the fracture neck femur treatment throughout these lectures. Now this FNS will just add you. What we want the further evolution is that you have heard that all the techniques have some problems and they're not fit for all the fractures. Like something is good for Powell 1, something is good for Powell 2, something is good for Powell 3. So we are looking for a solution which is easy, which can be done by everyone, and it can solve the problem of Powell 1, Powell 2, Powell 3. So to start with, what you need is, you have to evaluate what is the clinical problem and what is its solution. Then I will give you a little bit of FNS description and few case presentations because experience is very, very small. I have done so far 16 FNS in last 8 months. And because the pandemic also, a lot of work was not done in last 3 months. It was all stopped. Hospital work was not working. So we have done only 16 so far. Now, once you know that the problem is fracture neck femur, the important thing is your decision. And decision definitely depends upon age, bone quality, fracture pattern, reduction, and comorbidities. Age is such a thing that you cannot cut off that, okay, on 50, I'm going to do this operation, on 40, I'm going to do this operation. They are different for the different patients, and they're different for different surgeons also. Similarly, the bone quality is very important. If you have an osteoporous bone, the chances of collapse are more, shortening is more, so you have to take care for that. The most important thing is the fracture pattern. And fracture pattern, Pauwell has given us classification, what you call it Pauwell 1, 2, 3. It is up to 30 degree, 30 to 50, and 50 to 70. For me, you take Pauwell 1 and Pauwell 2 and 3 as 1. So we will divide the whole thing into the stable fracture Pauwell 1 and unstable fracture Pauwell 2 and Pauwell 3. Then another important thing is the reduction. Again, somebody can accept a reduction, a poor reduction also, and somebody wants a perfect reduction also. But the key is reduction is the most important thing, whether you achieve closed reduction or you achieve by open reduction. Today, the buzz is open reduction to achieve the 100% reduction. Then comorbidities, again important if the patient is diabetic, patient is hypertensive, patient is having rheumatoid arthritis, your treatment changes. For example, a 45-year-old man who is having a rheumatoid, the fracture neck femur, you cannot fix it. You need something different. For them, you need a total hip replacement. So everything keeps on changing according to these factors. Once you know these factors, you decide what you're going to do and then execute your decision. Now, the most important thing is to understand these Pauwell 1, they have compression element. They're not shearing element. So they are very easy to treat. But what happens if you put a screw in the center of the Pauwell 1? What is happening? That this will not take and this will cause collapse. There will be a virus because the screw is not supporting the inferior cortex. So what you need is that you need a screw which is just parallel to your calcar, and this will give you support. So there is no further virus. So this screw has to be inferior central. It will look inferior into the AP view, and it will look central into the lateral view. Then to check your retroversion, what you need is a screw which is just parallel and posteriorly, and it should check your retroversion. So this is very important when you're placing these screws. Your one screw has to be inferior central. The second screw, you have to be posterior central. Now, if you have higher shearing forces like Pauwell 2 and Pauwell 3, now this same screw which was supporting you in the Pauwell 1 will not work in power 2 and power 3 because it cannot resist the shear. High shearing forces, if you put these screws, they are not stable. You will not be able to resist the shear. This is, for example, 45 years female, fracture neck femur. You cannot make out whether it is power 2 or power 3. So for me, anything above power 1 is power 2, power 3, they are same. If you just see this axis now, if you just make the marker, you can make out that this is a power 3. And for power 3, if you do these 3 screw fixations, this is a conventional method. Everybody does like this. But what happens that within 2 weeks, the varus collapse with this fracture. So ultimately, these 3 cannulated screws or 2 cannulated screws in fracture neck femur, especially in the shearing power 2 and power 3, they can cause varus collapse, they can cause shortening, they can cause non-union, and at times you can have peri-implant fracture also. This is another fracture neck power 3, 50 years old female. I think this is the angular stable implant, which we have already discussed. Dr. Trikha has given you about DHS is one of the gold standard even today if you have done it properly. And this is the angular stable implant. It gives a perfect reduction, perfect surgery, and perfect results. Now, the problem is why we need a new approach. Because our routine implants like DHS, like 3 screws, they are missing the target. And that is the reason we have seen that somebody is putting a medial plate, somebody is putting a double planar or Pauwells. This is all evolution. We want something better to check, to resist the shear. So we still don't have that, we still don't have that particular implant which can help us. So what is the clinical problem? If you see the shear is the biggest problem, it stops your healing. It is causing disturbance in healing. And the varus and shortening, they ultimately lead to the shortening and they give you poor function. So even if the fracture unites with a shortening, there is a poor function. Patient is not satisfied. Now this is JBJSRT 2008 cannulated screws. They are not good at resisting shear and varus forces. So they are out for power 2 and power 3. The cannulated screws are good at compression, but poor to control shortening. Again, a problem. And it is almost 30% of the patient, they come with a shortening and they're not satisfied. This is another, you see that almost 120,000 patients were reported, and out of that, there were 10% of the complications. This is another 33% failure within 3 years. This is from failed internal fixation of femoral neck fracture in 2007. This is another quality of life following hip fracture, results from Norway hip fracture register. 60% patients were unhappy, either because of the shortening or because of pain or because of the limp. They were not able to go to their normal routine work. So these are the problems which are bothering us, that what best we can do for them. Sliding hip screw can prevent varus shear. Definitely it is a very good implant, but cannot stop shortening. Another problem. This is the most important. We have already discussed about this problem. There is a malreduction during DHS insertion. This is the biggest problem with the DHS, and it can cause malreduction upon insertion. This is GOT 2019. This paper shows sliding hip screw can also cause a secondary malreduction by spinning the head fragment, especially in the younger patient in the harder bone. Lancet 2017, they have compared the AVN between the 3 screws and the DHS, and they found there is a high rate of AVN, especially in the DHS cases. Another, Dr. Trikha said it's a very simple technique, simple instrument, because we are all aware of, we are doing for the last 30, 40 years. But I think it is very complicated, lot of instrumentation. Large surgical footprint, you can see that you have to, you can use even the 2 screw, even then it is quite big in comparison to newer implant. Lateral protrusion, most of the time you have seen that there's a shortening and there's a lateral protrusion and it causes high pain. That is another problem, because if you are putting an eccentric screw 1 and then you have to put it inferiorly, your TAD is disturbed. There is no connection between anti-rotation screw and angular stable implants. So the collapse is in a different way. The one is collapsing more, another is not collapsing. So there is always a varus deformity. And especially in the patients where the femoral neck is shorter, anti-rotation is to become difficult because 2 implants is difficult to put, especially in the Asian patients. So what is wrong with DHS? 2 implants not linked to each other behave differently. In a smaller neck fracture, it is difficult to put in 2 implants. We do not know how much is the collapse. We cannot control it. Hand spinning, strong rotation forces during insertion of DHS screw, it leads to malreduction. You can reduce it even during your DHS, even if you see that later on that you find there is a malreduction. So it is very difficult to control it, malreduction, especially in the strong bone. Then vessels are stretched, there is a vascular impingement, and that leads to AVN. So these are few complications with DHS, so we are looking how to solve them. Now the dilemma is, how do we allow needed fracture impaction for reliable healing, but avoid over-shortening and varus collapse of femoral neck fracture? And secondly, how do we avoid secondary malreduction leading to AVN? So these are the 2 main things which we are looking for, how to go with them. Now, this is the one approach we have already seen, that we do the open anatomical reduction, we do the intraoperative compression, and then we replace with the lag screw, what you call it a lag stable implants. This is one of the very good technique and very good results. This is another, the only problem is that in intraoperative compression, that is stabilize our lag stability, it's a very good results with minimal shortening. So this is a wonderful technique which we are already doing, but there are still failures. However, this method fixation has not entirely eliminated the problem. There is still, we have seen the collapse, we have still seen the non-unions, we have still seen the varus, even after putting this compression threaded screw. So now there's a different approach, which probably we thought another length stable implant, that you put a compression first and then you put a lock plate. But again, there was a catastrophic failure, so this is almost out. There are other alternative techniques, what we have already seen. You can use the Pauwell screw. It may not perform as good as DHF, but this is definitely one technique. But again, you cannot do this technique in all Pauwell 1, Pauwell 2, Pauwell 3, all the cases. Similarly, this technique, which has already been shown you such beautifully, it's a wonderful technique to check the shear forces, there's no doubt about it. But difficult for all the surgeons to do the open reduction and to fix it nicely. It is really a difficult problem. It is only good for expertise like Dr. Gavaskar. And I salute him that he has shown such a good exercise. And I think this is a wonderful technique. This is another biplanar. Agra people have already shown you such a good series and they are so happy. I think this must be very good. But the only thing is that it is not suited for the Pauwell 3 and it can cause complications like subtrochanteric fractures, etc. So again, there are problems with these techniques. The blade plate, it was to be used in 1980s. Now this implant is not there. We don't have sufficient data about it. So where does this leave us? There's no doubt about it. Angular stable implants are very effective in registering varus and limiting shear forces at fracture site. There's no doubt about it. The current implants, sliding implants, they allow you dynamic compression, but have a high rate shortening. That is the problem. The statically locked plate, you have seen the catastrophic rates of failure. The anatomical reduction, intraoperative compression, is stabilized with the stable length stable implants may prevent necessary impaction for healing. The fact is, these fracture love some continuous dynamic compression to heal, which was missing in the previous techniques. Now, what is the solution? Simple. We want a healing, maximize healing. How? Give a perfect compression, prevent varus, there should be minimized shear forces, and then prevent rotation during implant insertion. So that is our biggest problem. For this, we want some solution, that how to check rotation during implant insertion. Once you have done it, then maintain the anatomy of the proximal femur. You have to prevent the shortening, allow some compression, that is more important. You want to control shortening, but you want to allow the compression. I think this is the more important thing, which newer implants they have, and then you prevent varus. And preserve the offset of the hip to maximize the function. Now, coming to the FNS, I think this is one system designed specifically for fixation fracture neck femur. This is a very simple system, easily to be performed by any surgeon anywhere. Only thing is the cost. Probably the Karl Stoffel, who is the master behind this design, he is involved in design and development of FNS. And this product came in 2017. And believe it, that in 1990, in 100 years back, during the first pandemic, Pauwell has classified this fracture. Until date, we are still following the Pauwell 1, 2, 3. And today we have a solution by Karl Stoffel to solve the problem of Pauwell 2 and Pauwell 3. So this is the unsolved story of 100 years from pandemic 1 to pandemic 2. And we are still feeling that we should have something more to evolve to solve this problem. Now, the FNS is it's an easy surgical technique. A small surgical footprint in comparison to the DHS and the 3 screws. There is no lateral protrusion, so no thigh pain because it has a capacity of 20 millimeter collapse. The barrel does not come out, so there is no lateral protrusion, so no thigh pain. Center position of the neck screw with ARS is good for shorter neck for the Asian patients because these are the 2 implants in one implant, so they take lesser space. It is very easy to insert them. The connection between the bolt and ARS is very important, that these 2 components, they work together. It is not that acting separately. And then there is no rotation torque while putting the bolt. That is the beauty of this implant, that there is no torque at all. Now coming to the implant itself, if you just see that the footprints, you can make out that it is almost 3 times the DHS in comparison to these 2 implants. Now coming to the system description, there are basically 4 components of this FNS. This what you call it the barrel, and this you call it the bolt, and the third is the derotation screw, and fourth is your lock screw, simple lock screw. So there is a minimum size, left and right are same. There is a possibility of up to working from 125 to 135 degree, and the barrel is at 130 degree with 5 millimeter locking bolt. For this, you need a 4.3 drill bit. It provides you perfect angular stability, and the plate size are only 2, 1 hole and 2 holes. Usually we don't use the 2 holes plate. They are definitely with a set, but I think 1 hole is sufficient almost for all fractures. The bolt size comes from 75 to 130, and this screw is again of the same size, but the size of the bolt. If the bolt is 75, you have to use the screw 75. If the bolt size 80, you have to use the screw size. This comes as a one kit, except this screw. So all the 3 components, the bolt, the barrel, and this is anti-rotation screw, they come in one kit, and this is a separate lock screw. Now, this anti-rotation screw, it provides you rotational stability. It is a diverging design between ARS screw and the bolt. It allows implant placement even in a smaller femoral neck fracture. The plate, it provides you angular stability once you fix with the bolt. It accommodates 5 millimeter locking screw. It reduces the implant footprint of the bone compared to 3 cannulated screws. Now coming to the instrumentation, there is only one instrument, what we call it a handle. And this is just like a triangular handle. It has 3 components, one for entry of the plate and the bolt. Second for entry of the lock screw into the shaft, and this is called as this is the insert for your ARS screw. So it has all 3 different entry points. One for the plate and the bolt. This is for the anti-rotation screw, and this is for the lock screw. So it's a very simple instrument. You just put a simple K wire into the center of the neck in the AP in the lateral view and drill over that and just put this implant. So within 5 to 10 minutes, you can do the whole surgery. Now there are different companies, they are coming up with the same concept. Here we have the Esculap Dragon system. Then we have a Smith-Nephew conquest system. The results are not very good, not very satisfactory. There are a lot of problems with these implants. Now, just coming to the few examples, what we have done. This is a Pauwell 3 fracture neck femur. You can see that there is a varus deformity and there is a retroversion, and there is a combination also on the posterior side. So what you need is a simple, you just try your reduction, close reduction. If you can get a perfect reduction, you're happy. If you cannot, go for an open reduction. Then you put a central wire, it's a guide wire, and then you just ream over that, and then you just slide your bolt over the guide wire. And then you just lock it after putting that into the shaft so it becomes angular stable. And then you put your drilling for ARS, and then you put your ARS rotation screw. So by putting this, it is an angular stable implant, which has almost the same stability as DHS, but the rotation part is much higher than DHS. It is 1.5 higher than DHS capable for rotational check. Now, this is immediate postoperative X-ray. You see the AP view and the lateral view, central. And this is after 5 months. You just see that this was a Pauwell 3, completely rotated, comminuted. There was a retroversion, there was a varus. And after 5 months, if you see that there is no collapse and the offset is absolutely normal. So there is no question of shortening. There is no question of any limp. Abductors are absolutely perfect. Another example, 36-year-old male came with a complaint of pain in hip 5 days back, Pauwell 3, Garden 4. Again, center to center screw, FNS fixation. Then you can put some compression also with this implant. This instrumentation is so good that you can put 1 or 2 millimeter compression also. And this is final post-op picture of hip. And this is follow-up after 2 months. Fracture united within 2 months. There is no varus. There is a minimum collapse and offset is normal. This is after 3 months. You can see that the clinical presentation that after 3 months, patient is walking absolutely perfect. Usually these patients are starting movement almost after a month, they walk normally. Another case, 30-year-old female, 3 days back, she had a fracture with a history of 3 days back, Pauwell 3, Garden 4, subcapital fracture. This system was applied after proper reduction. This is follow-up after 1 month, little collapse, offset almost normal. Post-op after 3 months. This is after 3 months, she's walking absolutely normally without any support. Another case, 64-year-old male. History of 3 days back, patient had a valgus impacted fracture neck femur. If you just see this is a impacted, valgus impacted fracture. Pauwell 2, Garden 1. If you just see the CT scan, this is important in these fractures, especially the valgus impacted fracture. We have to see the CT, especially to see whether there is a medial hinge intact or not. If the medial hinge is not intact, probably this is not good for FNS or 3-screw fixation, they need a replacement. Second important thing, you have to check on the X-ray, on the CT scan, how much is the retroversion. So these are the 2 contraindications for an impacted fracture neck femur. If there is a retroversion on CT scan or there is a medial hinge is broken, then probably this is not a good implant, then you go for a replacement. So in this particular case, there was no retroversion, the medial hinge was intact. So again, we have put on a traction table without giving a traction. Impaction is still there. Put a FNS, and this is final post-op X-ray. And this is follow-up after 1 month. You see the fracture is completely united within a month's time. And this is after 3 months, there is no collapse. And this is the patient is almost walking comfortably without any limp. This is another interesting case. This is, I just added to increase the indications for this FNS. 75 years old male with history of fall 1 week back, more of a trochanteric fracture. So these are the fractures, simple fractures. These are also indication for FNS. Previously, I did this rail almost 3 years back. And now this is the closed reduction. Guide wire and drilling and putting the plate. And this is the final post-op X-ray. And just after follow-up 4 months, the fracture is completely united. So this is another indication you can extend for fracture neck femur to the basal trochanteric fractures where you can use FNS also. Especially in these cases, if you feel you can use a 2-hole plate rather than 1-hole plate. Only important thing, this screw should be a little bigger so that it is easy to remove if you want to remove this implant. If you put it the same size, then many times there is a lot of callus formation. It has become difficult to remove. So always put this screw a little longer. So to summarize, FNS is sliding angular stable implant with controlled collapse. That is the beauty of this implant, that it has a controlled collapse. It seems to be promising for Pauwell 2 and Pauwell 3, femoral neck fracture. For me, I think this is a green revolution because there is a minimum pollution at the surgery site. You hardly had a 2 inches incision, and you can do it in such 10 to 15 minutes. And it is so easy for everyone, for every fracture, whether it's a Pauwell 1, Pauwell 2, Pauwell 3, or a basal trochanteric fractures. You can operate all these cases by a single implant with a single instrument. Thanks a lot. Open for discussion.
Thank you, sir. So I would invite our panelists, Dr. Saraf, Dr. Gautam Chakraverty, and Dr. Kaushal Agarwal to take the questions and put in their inputs too.
Thank you, Dr. Jain. Very nice talk. Total, how many cases have been done? And what is the complication rate? And what is the cost of the implant?
See, the complications are very minimal so far. I mean, in my 16 cases, I don't have complications, but yes, there are a lot of cases are reported from different countries. Especially Japan has already done almost 3,000 cases. But if you see the European country, all the surgeons, they have a counting of 10, 15, 20. It is almost same what I have done. So our experience is very, very, very less. We cannot say, but so far there is no complications. But always that once any instrumentation or any implant, when you learn, there is a learning curve, there are some complications. But if you know the subject, if you know if you have the proper training, I think this is very easy to do and with less complications. Regarding the cost, definitely very high. At the moment, it is probably around 40,000 rupees, the complete implant. In comparison to DHS, if you take the DHS, it costs you 8 to 10,000 rupees, imported one. Local one, I don't know how much it costs.
Sir, can we stop this screen share?
Pardon?
Can we stop the screen share?
Oh, sure. I'm sorry. Yeah, go ahead.
Can I ask a question, sir?
Sure.
Why did the company design a instrumentation which can produce, which can allow 20 millimeters of collapse when more than 10 millimeters is actually very bad for fracture neck femur?
Definitely it is bad. There's no question about it. The idea is that if there is a collapse in osteoporosis patients, it can happen. At least the screw cannot come out. That is the maximum it can collapse. It has already a space of 20 mm. And usually it is very unlikely to have 20 millimeter collapse. Hardly 5 to 10 millimeter collapse is there, which is good.
I think there's a question in the chat. Okay, Amit, you are asking something?
Yes. Sir, have you any experience with open reduction in FNS?
No, so far I have not done it, but yes, open reduction we have done with the same technique, but Dr. Ashok has already shown you. But I have not done open reduction in this particular case in last 16 cases.
Okay. Can I make a comment?
Do you think it's going to be as good as for other modalities of fixation?
For me, today it looks, it's a wonderful implant, but we have yet to see that any complication which may come in the future with different experiences, but so far I'm happy.
Okay.
Can I make a comment?
Yes.
Yes, sure. Yes, go
Yeah.
ahead.
So as Dr. Mukesh said, like Japan probably has the highest experience on FNS because it was actually the brainchild of the Asia Pacific expert group, which then switched over to the lower limb group because of certain things. So Dr. Shoda and this group from Japan like probably has the highest amount of experience. And if you look at the complication rates in their series, it is still around 11%. So of course, like it involves a variety of fractures across all age groups. But that is the current, probably the largest series available on this implant right now. And I have used it as well, only just a couple of times, and one in a Pauwell 3. And it probably might work independently for a Pauwell 3, as Dr. Mukesh showed in quite a few of his cases. But like, I'm still reluctant. Like, I have used it in combination with other maybe an additional screw and to a medial plate. But maybe like it might work independently as well.
Yeah, sure. Actually, what the thing is that Pauwell 3 would always require a buttress from outside. If you want to avoid all that shear, it will always require a buttress from outside. And I don't think there is going to be any implant actually, which will be an intra neck implant, and will be successful in in resisting all that shear.
Actually, the complications which we have already seen in this Japan series, there are a lot of things because it's a learning curve. A lot of things have been done wrongly. So this implant will take a little more stability, say after 2-3 years, then we can say where we stand. But so far, what experience I have, I think probably it's very promising, very promising.
Yeah, true. Actually, like some of the complications in the Japan series are like not really exactly due to the implant, and they actually like had problems initially because their the lowest size available was 75, and a lot of these Japan patients were actually small, and they actually were actually pushing DPS for 70. So some of the initial complications were like, and a lot of complications that were seen were actually in the 2-screw group. And I think like gradually DPS might actually withdraw the 2-screw plate completely. I don't think there is a need for a 2-screw implant actually.
So what's the diameter of that bolt?
The bolt is 12 millimeter.
It's 12 millimeters. And the screws are the anti-rotation screw?
This is around 6.7.
So do you put it still in the center, or have you shifted slightly inferiorly?
It should be absolutely the bolt has to be in the center to center, and AP and lateral both. And this screw goes through your bolt, and it just divergent certain angle. So it just checks the rotation of the head.
The beauty of this FNS is that once you are putting in that anti-rotation screw and compressing it, you get beautiful compression, which is uniform and proper in direction. That's the beauty of it, because you already have an internal strut, just like Dr. Kapoor showed. There is a beam which is there right in the center of the femoral head, and the compression which is combined with it, it just compresses. So the compression, even if there is a gap out there initially, and if you want to get compression, what in our experience we have found that those 5 millimeter compression which is there, the gap, even if there is a gap, it beautifully stops and compresses with the anti-rotation screw.
Yeah. Okay.
No anti-rotation wire is placed before reaming.
No, nothing.
So how is the rotation during reaming checked?
Actually, because you see, once you have reamed it, now you can check. You can have one guide wire in advance, just away from the instrumentation, just to check your reduction, to control your reduction. And see, the instrumentation is so sharp that once you rotate it, it doesn't cause any rotational stress. The rotational stress is more during the screwing. When you put your screw, DHSA screw, then there is a problem. Here it is a bolt. It just slides inside. So there is no question of rotation or a stretching of the vessels.
Reaming also produces rotation.
Definitely. But that can also produce, but it is too minimum in comparison to putting a screw.
Sir, reamer और bolt size के बीच में difference क्या है diameter में?
There is no difference. It is same one. It just slides inside. You can just put the bolt and it goes in. You don't need a hammer.
The bolt is not non-threaded.
It's not. It's a very smooth.
It's a smooth bolt.
It's a shaft. It's a shaft sort of
You
a
will
thing.
call it a shaft.
And it has got a groove on each one side so that it does not rotate or anything. It will just slide into it in a proper manner. The groove on the opposite sides, which is there.
You cannot be wrong.
You cannot.
Every
Yes,
time it goes.
exactly. It will go only in one particular
In
plane
one
that it
particular
will
plane.
inside that barrel.
But Trikha sahab, isme ek hi gabad hai. Why did there is so much loud collapse.
So that is there, but
no,
as sir has said that it is not intended to bring out collapse. It is only that if it happens, it has got an additive measure which can prevent further surgeries by not allowing the lag screw to protrude out.
You know, Dr. Vivek, what I think is that this implant is going to be slightly incompatible with open reductions and anything which is applied to the neck from the outside.
Not really, actually. You can use it in open reductions. I don't think it matters.
The DHS is 12. Sorry. Yeah.
Yeah, sorry. And why it allows some collapses, like the previous systems that are relied on absolute no collapse, like the locking systems, had failed terribly. So if you look at all the current angle stable systems, do allow some element of compression.
Yeah.
So,
but only when you are doing surgery, Ashok.
What?
Only when you are doing surgery. They don't allow all these systems. Like, for example, even if you do a DHS with a fully threaded lag screw, what you are doing? You are actually compressing on the table, and then you are not allowing any further compression. Is that right?
That is the principle.
I agree with you. I agree with you, but then your reduction has to be absolutely.
That is why you do
pinpoint all the time.
That is why you need to do an open reduction.
Yeah. Whatever you do, like open or closed,
open or closed, doesn't matter.
And I don't think it's practically. I think the device has to be a less. If it had to be forgiving, then it has to have allow an element of collapse. Otherwise, it might be too rigid. I don't think I think that is the experience with previous locked systems for femoral neck fractures. I think the fracture also has to be taken into account.
But Ashok, what I think that we need to get more literature on the subject before we can actually have
it's a divergence.
We have to wait.
Jain sir.
Does the divergence of the two, the bolt and the compression screw, collapse? Does it?
Yeah.
Yes, it does.
For allowing compression, sliding back of the bolt, there should be some adequate or minimum length of the barrel. In a DHS, what we see that a longer barrel is needed for a longer screw. But in this case, the shaft is having a hold of just few millimeters for sliding. Will that prevent sliding? Will that fail? Any experience?
I don't think that. See, the only collapse is when there is osteoporosis, severe osteoporosis, and for that they have given a 20 millimeter collapse. We don't want any collapse, but it can happen. So that's why there is a space that it doesn't come out and it can collapse up to 20 millimeter. If there is a collapse of 20 millimeter, definitely the offset is going to be disturbed. There's no doubt about it. But what I have seen in last 16 cases, there is not any collapse even in the osteoporosis patients. We are lucky. I have shown you a patient of 85 years old with a impacted fracture. There's not any collapse in that, but it can happen. There's no doubt about it.
The series is too small.
Very small, very small. It is nothing.
And second, all said and done, with so many different methods in our hand, that means there is no single method which can take care of all the conditions.
Exactly.
If we go to the history, starting from the days of Whitman's plaster to this day, we have not yet reached any conclusion. We are still searching. And by God's grace, tomorrow we will find another method which will take care of all these problems.
It's
just one question. How does the bolt lock exactly?
See, the bolt is a bolt. See, there are two components. The one is the shaft. Shaft has through the shaft, the screw goes, it locks into the bolt. The screw, it locks into the bolt. So now these two things become one component. Okay? And this screw is in a divergent fashion. Okay? So once it is in a divergent fashion, it checks your rotation also. Which you are working with the derotation screw in the DHS. This screw is doing the same anti-rotation function. The good part of it is that it is one component. If there is any collapse or if there is any problem, it comes together. It's not that the one screw is working differently, DHS screw is working differently.
If I can say that one, sorry sir, that if somebody had to evolve the DHS further along with the derotation, this is the next step which had to happen. If you see that whatever complications I enumerated, which is the different things for the DHS, the bigger thing, all of that has been taken care in an FNS to ensure that all those problems are avoided as much as possible in the present day world.
See, it is any, yeah.
Sir, what I think the sequence of fixation should be particular in this, that first you have to put the shaft, then you have to put the screw, distal screw, and then you have to put the compression screw.
Yes.
Is it correct?
See, previously the sequence was different. Previously we were putting the shaft first, and then we were putting anti-rotation screw, and then we were putting the angular stable screw into the shaft. That is lock screw. But now it has been changed. You put the shaft first and then put the lock screw, because you want to make the plate parallel to the shaft. So many times it rotates anteriorly or posteriorly. So to check that, you just put your lock screw into the shaft, that it is in the right position, and then you put the anti-rotation screw.
So that was my query, because if you put that compression screw first and then you put the plate screw, and if it's not fitting into the shaft and you rotate it, that will rotate the fracture.
It has been changed.
That will change the fracture geometry. So you have, that screw has to be put last.
So if you see the brochure also, it has changed. So Dr. This thing is a point which everybody needs to note, because this might lead to some of the learning curve complications which can happen.
Somehow we started with putting locking screw first. When I read the brochure, then it was different. But I was very comfortable to putting the lock screw first and put the anti-rotation screw later on.
So what about the angles, the different angles you said 125, 31. You change the angle of the plate?
No, we don't change anything. We don't change anything. Okay. It is only the relationship of the shaft to the plate little change. It may be 5 degrees off the shaft.
Okay. So how to do that? You have
you put your, you just put it at 130 degree. You just put it 130 degree. You don't bother for the shaft. You don't bother for the plate to the shaft. That will be a little bit changed. Because you are putting a lock screw, so that doesn't matter.
Doesn't matter. Okay.
One more question comes to the mind, that when the locking derotation screw is fixed in the shaft, it will become an oblong construct. So oblong construct sliding in the round barrel, how can it be possible?
Actually, this is the beauty of the Swiss instrumentation and the implants. Once you will see the implant, you will appreciate that how it is fixed inside.
And once
it is magic. It's just a magic. You cannot.
Yes, all right. Then once there is collapse, which is being permitted, the diameter be increased, because it is not a barrel is not parallel. It is just divergent barrel.
True.
How will it accommodate in that round barrel? That also.
So there is a space. Both the things once locked, they move simultaneously, laterally.
So there is a play in the.
There is a place to move.
Place to move. Okay.
And I think, sir, you are having that locking bolt distally. You are not flashing the plate directly to the bone. It's not compressed. So there is so it's just in line. So the collapse will happen, because it's not produce any stress between that bolt and the barrel, because there is no pressure on that plate and screw.
See, whenever a new implant comes, there are always queries, there are always questions, dissatisfaction, satisfaction. It takes time. Even the DHS, see, it took long time to settle down the DHS is a good implant. Then we come with the derotation screw. Then we came with the completely threaded screw. So these are the changes we are learning. And now this is a good implant for you. Just try it, experience it, and add it to your armamentarium. It's nothing.
Just one more question. Is there a tip apex distance concept applicable here?
Yes.
Yeah, definitely, because we are putting center to center, so it is always.
We have an eccentric screw and we have a bolt. So how do we, from where do we measure?
No, the bolt, see, it is automatically the bolt and the screw are the same size.
Okay.
If you are putting a bolt of 80 millimeter, your screw is automatically 80 millimeter. Only thing is that it is divergent. That's all. And it has a capacity of collapse also. If you want to use a longer screw for more divergence, there is a collapsing technique, which I'm not going to go details. You can put a 80 size screw with a predetermined collapse of 5 millimeter or 10 millimeter. In that situation, then you can put a more divergent screws, anti-rotation screws. That is possible for especially the osteoporosis bones, where you feel there is a lot of osteoporosis,
yes,
and you want a divergent angle a little more. That is quite possible by the collapsing technique.
Right.
Pre-collapsing technique, we call it.
All right.
Nice. We have overshot the time by almost 1 hour.
It was so interesting.
But we had
when a webinar is to be conducted for 1.5 hours and it goes for 2.5 hours, it shows the success of the webinar.
Yes.
And actually, truly, this was one of the best webinars that I have attended, and I am attending a lot. So, and about the ignited minds, we have so many ignited minds on this panel, but I'm sure that the people who designed this FNS are equally ignited. So we can discuss it at length for years together. But people, I mean, because I've been to that center which makes these implants, and the perfection and finish with which they design it is unimaginable. Unbelievable. So let's rely on them and not apply our minds. So
see, just believe a single implant with a single instrumentation, nothing else. You don't have a big tray, you just have a small tray, take 10 minutes and do it.
No, sir.
It's beautiful.
But I would advise all people here, Dr. Mukesh Jain sir, you've always been a torchbearer as far as newer techniques and implants goes. But I would request all of you to try the BDSF technique.
No, that's a wonderful technique, no doubt about it.
It's a simple technique, and for our population, it comes without any cost for this
Absolutely,
fracture.
absolutely. No comparison. No comparison.
So just try it out. We may fail. One who tries does fail, but try it out.
Definitely.
So can
So
we
I
conclude?
think,
Can we conclude?
yes.
Now?
So before we conclude, a few short words from our seniors. Goel sir, I just saw him appear. Sir, few words from your bag of experience.
Yeah, I have been listening all through, though my video was off for some time because of some patient's problem. But it has been very illuminating seminar. It's a webinar. The only thing it was short the time, 2.5 hours. It should have been in 2 parts, I think. But,
that's why I requested 20 minutes.
But newer techniques, yes, of course. What Mukesh has told, this technique or FNS, that looks beautiful, and B.D.S.F also, what you said. And all of us must try these things, and then only we will be able to come up with a new good solution.
Thank you.
Because we all know whatever we have been doing, the complications have been there, so we have to have something good.
Thank you, sir. A few words from Ashish Kumar sir. Ashish sir, you've been just listening. So a few inputs from your end.
That's the same thing that I was listening all together, but it was so good, and I hardly had any question which was left to be asked. So if we can divide in 2 parts, one can be the FNS, the rest other can be. So it was very nice and very good, and congratulate you and the Varanasi Club for this. Thank you very much.
Thank you, sir. Few words from Dr. Kamraj, our club secretary.
I must thank everyone. I mean, it has been a wonderful session, and there was so much to learn, to imbibe, and we look forward. And I think our association would give out special prizes to all the surgeons who start doing all these various techniques to encourage everybody to come up with exercises and surgeries like this. So in the next future, whenever we have meetings, we will make sure someone or the other comes up with such cases and adopts these techniques. So it has been a wonderful session for all of us. Thank you so much.
Thank you. And finally, I would like to pass on the mic to Rakesh sir, our club president, for the vote of thanks and the concluding remarks. Rakesh sir.
Yeah, Unmesh, thank you so much. I hope you can hear me. It's been a wonderful time seeing the salvage of the neck fracture of the head in the neck fracture situation. And I think you must conduct a couple of workshops on the technique of some of these techniques, and we go deep into them. And I think as we are running short of time, the viewer takes all the pleasure to congratulate all the speakers, Dr. Amit Rastogi, Dr. Vivek Trikha, Dr. Ashok Gavaskar, and Dr. Arun Kapoor and Dr. Mukesh Jain to share their experiences with their presentations. We thank the President of the U.P.O.A, Dr. Sanjay Dhawan, who chaired the session, President-elect Dr. Ashish Kumar, and our Dynamic Secretary of the U.P.O.A, Dr. Arun Kapoor. The special thanks goes to our panelists, Dr. S.K. Saraf, Dr. Gautam Chakraverty, and Dr. Kaushal Agarwal. Special thanks to our moderator, Dr. Unmesh, who planned and orchestrated the whole of the show, and our appreciation to the delegates for the active participation and patient hearing. All our regards to the OrthoTV team and the sponsors of the event, Johnson & Johnson. Yeah, over to you, Unmesh. Thank you so much. Thank you so much, all.
Thank you so much. I think we had a wonderful day. Thank you again, all our seniors, teachers, and friends, and hope to see you next Friday.
I think
Okay, good night.
Thank you.
Good night.
It's wonderful.
Wonderful.
Thank you.